Um,
Morning, everyone. Today I'm going to present a journal, and my moderator is Dr. Sanjeevi ma'am. The title of the article is Psychological Consequences of Long COVID, Comparing Trajectories of Depressive and Anxiety Symptoms Before and After Contracting SARS-CoV-2 between matched long and short COVID groups. About the journal, the British Journal of About the journal, the British Journal of Psychiatry was originally founded in 1853 as an asylum journal and was known as Journal of Mental Sciences from 1858 to 1960. It is one of the leading international peer-reviewed journal covering all the branches of psychiatry with particular emphasis on clinical aspects of each topic. Owned and managed by Royal College of Psychiatrists and published monthly by Cambridge University Press on the behalf of the college. The impact factor is 4.3. Author, the principal author is Daisy Fancott, and the other authors are Andrew Steptoe and Fifi. Publication, British Journal of Psychiatry, volume 222, issue 2, February 2023, and the conflict of interest is none. Funding the COVID-19 social study was funded by Newfield Foundation, but the views expressed are those of author and not necessarily the foundation. The study is also supported by March Mental Health Network, funded by Cross-Disciplinary Mental Network Plus Initiative, supported by UK Research Innovation and by Wellcome Trust. The principal author, Daisy Fancott, was funded by Wellcome. Why this article? There's a growing global awareness on the psychological consequences of long COVID. Most research on this topic has been limited to relatively short-term follow-up, typically just for a few months, and involve limited waves of data collection during the follow-up. Not many studies showing long-term trajectories of psychological symptoms over time are present. This study presents one of the largest and the longest studies to date of the psychological experience of patients with long COVID. Introduction. The average recovery time for from COVID-19 is 2 to 3 weeks, depending on the symptom severity. 1 in 5 people, regardless of the severity of their acute infection, may exhibit symptoms for 5 weeks or more, and 1 in 10 may have symptoms lasting for 12 weeks or more. Long COVID is defined as continuation of symptoms that develop during or after acute infection with COVID-2 beyond 4 weeks. These symptoms cannot be explained by any alternative diagnosis. So, the neuropsychological symptoms of long COVID include memory loss, amnesia, difficulty thinking, inability to concentrate, brain fog, cognitive impairment, disorientation, delirium, sleep disorders such as insomnia, visual disturbances, anxiety and depression, and thoughts of self-harm. The aim of this study was to examine when psychological symptoms first emerge following SARS-CoV-2 infection and to explore the mental health trajectories of people experiencing long COVID compared with those of short. So the data is collected from a previous study, which is University College of London COVID-19 social study. It is a large panel study of the psychological and social experiences, which includes over 75,000 adults in UK during COVID-19 pandemic. The study commenced on 21st March 2020 until November 2021 and involved weekly and then monthly online data collection during the pandemic. The participants were recruited via convenience sampling and targeted recruitment of the underrepresented vulnerable groups were done. The process of data collection. The total sample size of the UCL study was 73,242. From this sample size, only the people living in England was chosen, which those were 59,803. Out of this, there was a module that was introduced. In that module, the questionnaire was overall, do you believe you have ever had COVID-19? And there were these 5 responses. On the basis of these 5 responses, the people who did not have COVID before November 2019 were excluded. So the people who have COVID till 2019 were 25,289. Out of this missing that data were excluded. And then from the COVID-19 sample, the next question that was asked was, if you ever had COVID-19, when did you first contract it? On the basis of this questionnaire, the people who contracted the COVID before 21st March 2000, before 21st March 2020, that is before the commencement of the UCL study, were excluded. So and then the people who had COVID-19 more than once were excluded. So the final sample came out to be 3,150. The following were the questionnaires that were used. Overall, do you believe you have ever had COVID-19? Yes, confirmed by positive COVID-19 test. Yes, confirmed by positive antibody test. Yes, suspected by the doctor but not tested. Yes, by my own suspicions, and not that I know of. Study considered both patient with positive test and both with suspected cases as having had COVID-19 to be included in the study. The next was, do you consider yourself to have long COVID? And yes, the medical professional had formally diagnosed me with long COVID. Yes, I have not been formally diagnosed, but considered myself to have long COVID. No, I do not consider myself to have long COVID, and I am sure. I am unsure. Data recorded into binary variable yes and no, with unsure being treated as not having COVID. These were the other 2 questionnaires which had severity for the first 2 weeks and the symptoms. The 2 groups, patient, the severity for the first 2 weeks, I was hospitalized. I experienced symptoms and had to rest in bed. I experienced symptoms but was able to carry on with daily activity, and I was asymptomatic. And in the symptoms, my symptoms were worse at the beginning for the first 1 to 2 weeks and then got better. My symptoms were worse at the beginning for the first 2 weeks and then mostly got better, but some lingered. And after first to 2 weeks, my symptoms got better, but then the same symptoms kept on coming back. After the first 1 to 2 weeks, my symptoms got better, but then I developed new symptoms. Most of the symptoms lasted for 2 to 3 weeks. Symptoms lasted for 4 to 12 weeks and more than 12 weeks. And the last option was, I cannot answer this question. The 2 groups, the patient with long COVID and patient with short COVID, were created. They were created on the basis of propensity score matching. Propensity score matching is usually done in observational studies in which randomized control trial is not possible. It is a type of statistical analysis in which we compare the variable, the covariates, the various covariates, and then divide the groups into 2. These So the various covariates taken in this study are gender, ethnicity, age group, education, income, employment status, area of living, living situation, number of close friends, usual social contact, twice a month or less, once or twice a week, 3 times a week or more, self-reported diagnosis of any long-term physical health, and self-reported diagnosis of any long-term mental health. Then depressive symptoms were measured using a patient health questionnaire, PHQ-9, and anxiety symptoms were measured using generalized anxiety disorder assessment, GAD-7. To differentiate the experiences post-COVID from the usual mental health experiences during the pandemic, growth curve models accounting for lockdown and other social restrictions and the time of year were used, tracking individuals 10 months prior to the infection and 22 months on the follow. The analysis of the 3,115 patients that were considered for matching, the propensity score matching was done. Out of which 481 participants matched with the control. So the total participants remain 962. The analysis was carried out using Stata version 70. The people who were unsure if they had any long COVID, if the individual reported having COVID and subsequently indicated that they got better within 2 weeks, and if the individual reported not having long COVID, but also reported they had a symptom lasting for more than 4 weeks, were excluded from the analysis. Results. There was no difference in the long-term COVID and short-term COVID group in anxiety and depression before the starting of the for the acute infection. There was no difference in long-term COVID and short-term COVID group in anxiety and depression. During the acute infection, the people with long COVID has 1.3 points higher depressive symptoms as compared to people with long COVID, which was seen from PHQ-9, 16% higher score in people in acute infection with long-term COVID. Over the time, there was no evidence that these two groups differed in the growth of the growth rate of the depressive symptoms. In anxiety, the 10 months before contracting COVID-19, there was no evidence that the two COVID group differed in either the intercept of the growth rate or of the anxiety symptoms. At the time of contracting the infection, people who went to develop long COVID were slightly higher in anxiety levels, like 0.52 higher in anxiety levels as compared to people contracting short COVID. Over the time, the anxiety symptoms of long COVID group were less likely to decrease. The anxiety symptoms of long COVID group decreased less as compared to the anxiety symptoms of short COVID group, which even came lower than the pre-COVID levels. This is a table which shows that the depression symptoms, between the difference in the depression in between the long COVID and short COVID, there was a difference of 1.30, and the difference was significant as the p-value is 0.001. Similarly, for the anxiety symptoms, the difference between the pre-COVID and the post-COVID was 0.52, and the p-value was 0.145, making the p-value 0.145, making it not significant. Discussion: the inflammatory mechanism could be at play in the development of anxiety and depression. Fear related to contracting the virus could also exacerbate the mental distress, especially as the level of worries about catching COVID and potentially becoming seriously ill from it have been associated with heightened anxiety and depression across the pandemic. The long COVID group experienced greater increase in the depressive symptoms immediately following infection. This complements the previous work suggesting that the ability of COVID to raise levels of systemic and neuroinflammation may be greater in the patient with long COVID. There is no significant difference in the initial increase in the anxiety level between the two groups. Thus, increase in the depressive symptoms among the patient with long COVID is biologically driven by the viruses rather than manifestation of greater predisposition to emotional distress during the illness. The study highlights the need for monitoring of mental health and provision of adequate support to be overthrown with diagnosis and treatment of physical consequences of COVID-19. The strength of the study is that it is a long follow-up for 22 months, making it the longest and the most detailed follow-up of psychological experience of patients with long COVID. A propensity score, which is a statistical tool to categorize without randomization, being used and to reduce the confounding bias between long and short COVID group. The limitation is a self-report of the date patient contracted COVID-19, which could have resulted in the recall bias. No formal diagnosis of COVID made. So it is possible that some participants' symptoms are caused by some alternative illness. The sample is not representative of the population who have had long COVID, especially with more severe ongoing long COVID symptom may have been likely to be drop out of the study. Data of the psychological experience in people with COVID who were asymptomatic was lacking. The critical appraisal, the title of the study is clearly stated what they want to study and the study population, but the study design is not mentioned. The author conflict of interest is declared and the study is funded. In the methodology, no hypothesis was laid before the starting of the study. Study design and the type of study not mentioned. Data collected through an online platform and no one-to-one interaction with the patient. Self-reported diagnosis of COVID-19 and severity of symptoms and long COVID use. PHQ-9, which is a self-report questionnaire, but it also recommends that all responses should be verified by the clinician, taking into account how well the patient understood the questionnaire, which is not possible on an online platform. The results were concise and easily understandable. The results are arranged adequately according to the tables and graph. The study finding is explained and appropriate reasons given. However, dropout and loss to follow-up data is not mentioned.
How did they evaluate the anxiety and the perception?
So PHQ-9 and GAD-7. So they did not mention how did they apply and what is the
PHQ-9 for depressive symptoms and GAD-7
for
GAD-7. GAD-7 is self.
online.
Before COVID. Maybe they were a part of some other study. ये जो एक paper है.
This is a part of another study.
Another study. वो other study है. Did you try to make what was that study that followed? आपको मुझे पूछा था जहाँ पे शुरू किया हमने Yes, this one. Total sample was 17. ये sample का
that this is a sample of the UCL study.
UCL study.
Sir, from the UCL study, they have just taken the sample and nothing.
Do you know what is that UCL study? Sometimes one big follow-up study they will start. They will take cohort of patient. There are many clinical trials in this. Say they take a cohort of patient and they periodically keep on checking everything in that patient. For example, anxiety, depression. They will also study serum cholesterol, blood sugar, etc. in that cohort, and they will try to find out, say, what are the problems. So it gives you better etiology follow-up studies. So they may have been studying even before the COVID started. This study may have been going on, and then they just used the data. That is why, because they did not know COVID was coming 8 to 9 months. They were collecting data even before.
But the UCL study was started in COVID only, March 2020. Yes.
Or it is like they, where did they take the sample size? Is it that all the patients who are coming there in the hospital, they are undergoing this assessment?
But this is a UCL study that started on March 2020 with the starting of COVID.
Okay, so they then said long COVID cases were.
They were all psychological and social experiences. So long COVID के अलावा भी they were actually long COVID का concept था नहीं उस time पे.
सबको स्टडी करना चाहिए.
सबको स्टडी करना.
लेकिन उनका इंक्लूजन आइडिया नहीं.
मार्च में आया कोविड, उन्होंने पहले शुरू कर दिया कि हम स्टडी करते हैं कि कैसे होगा. दे स्टार्टेड अप्लाइंग एवरीथिंग. वैसे ऐसे करते हैं. 20 में तो लगा
हमारे
could be SN 21 study किया यहाँ पे, which we studied for patients who are coming where they had COVID or patient one year. Published the paper, not publish it. एक paper present किया था Dr. Mantal ने. So you can do it, like you know that this is going on. A lot of people started working on COVID. That is there. Strengths of the study.
It is one of the largest follow-up studies. They followed it for 22 months.
Okay.
And also the propensity score that they have used. This has, because of which they have achieved a good matching quality. So the chances of biases are reduced. So there is no confounder bias. But
they have to compare, like matching to क्या होना, compare सिर्फ long COVID और short COVID को क्या normal को नहीं.
But then there is also this one confirmed cases are learning major people suspect भी कर रहे हैं बहुत जो कोविड में. सही है ना? और finally the takeaway is कि COVID itself worsens depression, which is not anxiety about the disease, which is actual real biological situation. यही हो सकता है.
लोगों ने भी किया ना. Suspected का ऐसे जैसे कि also thought कि will be called COVID patients. So suspected is like suppose one person has a confirmed case and a family member has symptoms but not tested. But you know that he is going to have COVID. Just take a symptom. अगर लोन कोई पेशेंट होगा उसको सिर्फ सिम्टम होगा तो वो हम उसको तो कहना मुश्किल है. But 4 members in family, 1 or 2 have got the test. बाकी दो ने कहा कि हमको भी बुखार वगैरह आया था, खांसी भी, पर हमने टेस्टिंग नहीं कराया. So we presume that is COVID. But I doubt if they यहाँ पे तो सब ऑनलाइन था, 1-to-1 नहीं था. वैसे तो उन्होंने purposive sampling बोला है. They would like, even the methodology that they called the person and only took people who had definitely exposure and then symptoms. तो ऐसे भी कर लें, कुछ more करने के लिए तो then it was more. You can say it gives more strength. Otherwise, somebody saying that I have COVID, I don't know, no, we COVID हो गया तो थोड़ा सा नहीं हुआ है. Short with illness हो सकता है. यहाँ पे बहुत से पेशेंट्स थे जो कि डिस्चार्ज होने के लिए तैयार नहीं थे कि अब डॉक्टर ने बोल दिया ठीक है आपका ऑपरेशन ठीक है, नहीं कफ तो आई रही मेरे को, घर जाके कुछ हो जाएगा. बोल रहे हैं कि नहीं होगा, you are able to try. Now it is not like, no, do not have develop hypoxia or anything, but not use. Yeah.
So first,
JR3 comments.
also there is some when if there is some acceptance and if there is like social support and governance, so that also is going to increase the immunity.
Let us focus on the information.
So this was a study. Impact that individual.
ये कमेंट क्लियर है आपने कितना बताया बैक 4.33 your comment
Is that first of all, there was not a clear diagnosis of COVID. The first the point which we taken that it is in developed syndrome. Many during COVID and then all the questionnaires are online, so there is a clear doubt. We are unable to hear people. This represents
okay the comment did it do any statistical like comparison? No, just only logging of the chart is there, no incentives. That's all.
timer.
Why did you take this study? Was interested about this.
Actually, it was taken because we have limited access to Christian journals here. First of all, we tried for immediately now, we couldn't find access. Library में कहते हैं library में भी नहीं मिला.
लाइब्रेरी में ऑनलाइन हमारे पास कई उसमें वो साइंस डायरेक्ट का
There are journals also, latest journals available in the Indian Journal of Psychiatry and Patient Secretaries.
But somehow that Saya will be download maybe it is that is something.
but we can take previous articles also. Some can say